Can we go live?
Yeah, you are on live, sir.
Okay, you can start.
A very good evening to all our honorable guests, medical professionals, faculty members, and my dear fellow students. I am Muhammad Shafi from Academic Wing of Medicine, and I'll be hosting the session today. Welcome to ONCOVISION '26, an initiative by Medicine dedicated to the evolving landscape of oncology. Today, we gather for an exclusive academic address that promises to bridge the gap between current clinical practices and the future of precision medicine. It is now my distinct honor to introduce our chief guest and speaker for this evening, a name that resonates with leadership and excellence in the medical fraternity. Dr. J. Jayalal Sir is the Dean of Tiruvannamalai Medical College and currently serves as the Honorable President of the Commonwealth Medical Association, a former National President of the Indian Medical Association. His contribution to medical education, health policy, and surgical excellence have earned him worldwide recognition. Beyond his administrative and clinical roles, Sir has been relentless advocate for rights of medical professionals and advancements of affordable healthcare. Today, he will enlighten us on advancements in cancer treatment, innovation, precision, and hope. Sir, we are deeply privileged to have you with us. Sir, please.
Yeah, you allow us to share now, this sharing?
Yes, sir. Yes, sir. You can share, sir.
Okay, okay. Oh. One minute, it is not coming.
Yes, sir. Now your screen is visible, sir.
Is my slide is visible now? Or?
Yes, sir. Your screen is visible now, sir.
Okay, okay. So thank you for this opportunity to be with you. I personally congratulate Raghunandan and the medicine. I know for the last few years that he is doing a wonderful job. So once again, it is a pleasure and privilege for me to join with you. Due to last few days, I was extremely held up and busy. So I'm not exactly going to talk in general, but I'm going to talk to you on recent advances in the management of breast carcinoma. So that will be the topic for discussion today, where we will be talking about the recent advances in the diagnosis, recent advances in the management, in particular to the breast carcinoma, than talking in general. So we know that is one of the very much important and the growing disease is the breast carcinoma. There's a number of people now being affected with the breast carcinoma globally increasing. That has become a #1 disease. And if you see the statistics, and almost 1.38 million people, that is almost 13.8 lakhs people are getting the new, every year they are getting the breast cancer. And it is estimated in every 4 minutes, once in every 4 minutes, one of the Indian women is getting a cancer. And also this most important is, this is one of the largest killer disease. There are people who get a cancer, but all the cancer disease may not go as a killer disease. But this cancer is one of the second leading cause of the death which is happening today in our society. And if you have 8 women, and one among 8 women is the incidence of the cancer which is happening. So it is one of the oldest disease, but still we are getting this disease for quite a long time. It is quite a old and ancient disease which came. Every 13 minutes and one woman is dying And if you see that every once in 4 minutes, one person is getting the carcinoma disease, but every 13 minutes, and we are losing it. So that is why it is very significantly now it is coming. So it is the commonest and the most highest incidence of the disease is among the ladies. Olden days, if you see that previously 20 years back and 30 years back, it was noted cervical cancer is the top disease in the female. But with the advancements in the lifestyle, the number of cervical case incidence has come down, carcinoma. But with the lifestyle modification and a lot of metabolic activities, now we have the carcinoma breast as the highest thing. In average in India, the incidence is 31.3% of the population among the percentage, but few states are very high. If you see the Kerala, the incidence is extremely high. It is almost 45.7, but some of the states, Delhi is also 37, Tamil Nadu is almost 42.6%. People are getting in disease out of 1,000 people. You get 46 people, 47 people are getting infected. So it is a highly progressive disease. The most important thing is the mortality. It also differs from country to country. If you see the Western world, if there is 100 people with the carcinoma breast is being diagnosed, the mortality is only 17%. In America, almost Europe, it is coming to 27%. But when it comes to Asian countries, it is almost 34% of the people are dying. So if you have 100 people are getting carcinoma, our treatment modalities and our diagnostic modality are such that, and we will be able to only cure the almost 60% of the people, and 34 so the people are getting dying. That is very worst in African countries. African countries, almost 46% of the people who are getting this disease. So the regional variation of the incidence of the disease and the regional variation of the mortality is there. The countries where there is a early diagnosis and appropriate treatment are there, the death is less. But country like Africa, or country like even some of the countries in Asian countries, and where we are not very much developed, and there is increased mortality is there. No age group is spared. Even if you get a 20 years age group, we are getting carcinoma case. And of late, nowadays, we get more of these cases in the younger age group. And usually with an advance of the disease, the carcinoma incidence is also increasing. So there is this slide, I just want to be very particularly want to discuss on that is, we have different kinds of cancer type. One is a sporadic cancer, familial cancer, and hereditary cancer. We'll come to that and what it is in the later next slide. But sporadic cancer is that cancer always comes with a mutation in the gene. And when the sporadic cancer is one, where there is no mutation which is inherited, it is due to various environmental factors, various stimulant factors, the particular gene go for mutation, and that is common. We get, so almost 75% of the cases are sporadic. So what are the stimulant? Lot of metabolic the diseases like obesity, alcohol, all that is going to contribute. There is only 5%, 5 to 10 is a hereditary. That means it runs in the family. Then it is from birth, you are inheriting the mutated gene. So you are going to get that particular disease. And usually you are going to get the disease at the earliest part of the life. There is in between this, there is a familial breast cancer. That is in between. That is not exactly the hereditary. It is not transmitted from particular gene. But this is the overall, there is the stimulant and mutation is taking place. It can runs in family, but most of the time the disease will come in a people with a different kind of the age group. So this is a slide to say, if you see the sporadic is a normal at birth. The genes are normal at birth. There is a mutation take place, and then the tumor develop. So that is called sporadic diseases. So majority of the carcinoma of breast are sporadic. 75 to 80% are sporadic. That means it is normal baby. It is no relations with the family, but because of her lifestyle, and they are going to get the disease. But the typical inherited is only 5%. That is the mutation at birth itself. The genes are getting mutated in the mother or the parent. So that is also transmitted to that. But the familial is in between that. It is more than two members in the family will be affected. It is need not be in an younger age group, that can be at the age of even more than 60. it is not necessarily a corresponding cancer. Somebody, the parents may have a carcinoma stomach, and the familial, if it is there, you can develop a carcinoma because they are potently, you are more potent for that. You are imminent to get that disease. So this is a 3 terms which all of you should, as a student, you must know. What is hereditary cancer? It always runs in the family. Sporadic cancer, the mutation that is taking place at the delivered, and there is a taking place. The familial is in between this cancer. So can we call the breast this cancer as a metabolic disease? Now what we call diabetes is a metabolic disease. Now NCD, most of the NCD we say it is a metabolic disease. Can breast cancer? Majority, yes, both, though it is not a typical disease, but various factors which helps in the development of the breast cancer, that obese and metabolically unhealthy subject are very highly associated with the development. Metabolic syndromes, that is obesity and hip waist ratio, the cholesterol level. So all that, they contribute to the development of that. Lifestyle, reduced physical activity, that is also going to stimulate. So by that we mean the metabolic activities are going to be the important thing. So we need to the areas which are more prone to develop the metabolic disease are: one is overweight, alcohol consumption, hormone replacement therapy, your diet which you are going to take, and physical inactivity. We will go one by one. That exercise, is it going to help you to prevent from cancer? Yes, of course. The 25% reduction in breast cancer risk in a postmenopausal and most vigorous exercise we can note in the people who have a good exercise, just walking for brisk walking for 10,000 steps, or exercise, at least weekly exercise. You keeping your body fit. You don't be a sedentary lifestyle. So that means that you will be able to reduce the incidence of the carcinoma by 25% of the things. And the physical activity lowers the circulating levels of hormones such as estrogen, leptin, and insulin. And it also reduces the related growth factors and levels of the chronic inflammation in the body. This helps in the combating the cancer development and progression. Sleep. This is another important finding which we get. It is a main regular nighttime sleep because of the use of the melatonin. Now that's why there was a lot of people take a melatonin nowadays that it induces sleep. So the sleep per se, if you are doing a good sleep, that is a preventive for carcinoma breast which you have. And most importantly, the obesity. Obesity, especially the obesity which is coming after the post-menopausal period. In the pre-menopausal period, if you see, the estrogen is coming from different sources. We have an ovary which is secreting, and the adrenal are going to secrete something. But in the post-menopausal woman, the source of estrogen is only the peripheral conversion. That is, peripherally, the estradiol will be converted to estrogen. So wherever there is in the post-menopausal woman, when there is a lot of deposition of the fat, and that always get into the estrogen. You must all know estrogen is the most important culprit in the carcinoma breast, and wherever estrogen is excess, and we are going to get the disease for that. So that estrogen. So after the menopause, the estrogen made by the fat cells can make the cells multiply faster in the breast and increasing the risk of the cancer. And it also related with the insulin and growth factors. So the excess fat can always increase the level of the insulin and the other growth factors, which also tells us that it can develop into that. The third is inflammation. So nowadays, the most important hallmark word is the anti-inflammatory drugs, anti-inflammatory food. That is the whole of our body. Then all the disease, they are attributed to the inflammatory stimulation. So the cells in the fat called macrophages, and they are more sensitive the inflammatory cells, and they try to secrete more cytokines, and thereby by stimulate and produce the cancer. So what we mean to say, emphasize the obesity, especially the obesity which is going to occur in the post-menopausal woman, is one of the most important predisposing factor for the development of the cancer. So if you can keep your body fit, if you keep your body in the physical stature of the body in an appropriate way, not much of the fat, and it can always help to reduce the incidence of that. And coming to the alcohol and the smoking, and women who have 3 alcoholic drinks per week have a 15% increase in the higher risk of the carcinoma breast. And why alcohol increases that? If you see nowadays, we go to the hotels or bars or other things, we are seeing now increased incidence of drinking in the habits of the woman also. That's previously we all thought that it's a taboo for the woman to take an alcohol, but with an IT field and the growth which is happening, and there's a lot of people now start drinking, and that is the one reason where it has been the carcinoma breast has been happening in a much higher level. There are a lot of areas where the estrogen itself has an chemical phytoestrogen, so that is one area. The estrogen, the alcohol, it stimulates the estrogen sensitivity of the body, so thereby it even if you have the normal amount of estrogen, the impact it is going to create in the body is going to be more. Alcohol is going to have a problem with the liver, and the liver is a sex binding hormone secreting the albumin and globulin, and that is also will decrease. Thereby, the circulating level of the estrogen will become high. So the alcohol plays almost 15% higher risk of developing that. So this is the one study which has been recently done in a Western country, not in our country. People who have take alcohol, that is alarming to see. There is many people, many percentage of the people are taking alcohol in the woman. Then so smoking, cigarette smokers have 10% increase of developing breast cancer. So if you see cigarette and alcohol put together, you are having an incidence of taking 25% increase. Your fitness in the body, another 25%. Your good sleep can reduce 10. And if your estrogen levels and the peripheral obesity going to increase. So almost, and if a woman is really interested, and if you can make her life fit, 85% of the cancer incidence in the breast can be reduced, because 5 to 10% comes from the family, which is not, you cannot do anything, because the gene itself, what you are going to get from your parents are going to be a mutated genes, and that will result in always you get a problem. But once you are you do that, the sporadic cancer, the 90% of them can be prevented, and it can be kept in a big way. Food also plays a major role. The way the amount of food you take can increase that. These are the food which can help in reducing the incidence of that, especially the fish which you are going to take, the onions, legumes, and garlic which you are going to take, and cruciferous vegetables. All this can help you in reducing that. Now you all know, normally when any cancer we use the symbol as a pink symbol, pink as the color for the cancer. But in a carcinoma breast, for the food, it is also called as an orange. Orange is the colored food which are going to help in the prevention of the carcinoma. So all orange foods, whether it is sweet potato, whether it is the butternut squash, or the mashed pumpkin, or you can mango, apricots, the grapefruit, and even papaya. All these are called as yellow fruits, so, yellow or orange. So now the term we say is an orange food. So any food material which is orange in color, that is going to help the individual from not getting the carcinoma. So food also plays a major role in that, and how you are going to do the food. And another very interesting story is our gut microbe. Now most of the studies and research is going to be on the gut microbiome. And natural, as you take the food and the different kinds of food you take, our body, our stomach, and our intestine has a lot of microbiomes, and it is millions of microbiomes are there, and it is inherited to you, and genetically they are determined in your body, but the food can alter it and make it bad. So by studying the gut microbiome, now we are in a position to detect and say this person is going to have a cancer. So there is a lot of studies are now taking, and you can take the gut microbiome DNA studies you can do, and you can say the prognostic way. So gut microbiome has an impact on that. Gut microbiome, breast cancer, and drug resistance. So much of purpose, so much of research is going on with the gut microbiome on the cancer. And most importantly, which is preventing one, is a breastfeeding. So the breastfeeding, how it going to prevent? And the cells of the follicles of the breast is the most important, the terminal ductal lobule, what we say TDLU. So that is a basic unit of a breast. And the TDLU has a different pattern of growth, level type 1, type 2, type 3, type 4. So the type 3 pattern, which comes after the pregnancy and the breastfeeding, is always protected. So anatomically, by pregnancy and the breastfeeding, the TDLU go for a transformation in an anatomy. So that is going to be help in the prevention of the cancer. And also, we all know in the life, we know when you are idle mind is the devil's workshop, we say. When the process of breastfeeding, the cells will be destined or the program to develop a milk and as quick as possible. So as they are going to develop the milk for the 24 hours, and they will not be able to do anything of any mischievous activity. So that is what we say, the milk production, which is going to be the 24 hours, because every 2 hours you need to feed the baby. So once you fed the baby, the cells will be restrained to work on the breast milk. So they will not go into a different kind of problem. And whenever you are in a breastfeeding, you will always take a very nutritious food, and that results in the you are not, your body is having a protective factors. You are not developing a complications of that. So that's the most important thing. But now we normally say there are predictable reasons with which you can get a cancer or not. There are a lot of ways in which it's been worked out. So some of you may be knowing that Gale model and class model, which are responsible for developing the this kind of development. I think I'm not going to the much details of that. So there are risk factors. Very importantly, age factor. So age, as the age is going to progress, and you are going to get the more number of the carcinoma diseases. And most importantly, the family history. The first degree, if your parents or anybody who is in your family is going to get the cancer, definitely you are going to get a cancer. And another very important factor is age at menarche and age at first birth. This is very important for the age at menarche is going to play a very important role, because the uh, premenstrual area, when suppose the woman is getting the menstruation in a much earlier period, and the cycle which you are going to get will be an anovulatory cycle. That means the ovulation will not take place, and because there is the FS surge will not be there, thereby the ovulation is not taking place. Why this is not taking place? Because the hypothalamus pituitary axis is not functioning very well. So once the pituitary is not developed much in the early part, the cycle, it will be a anovulatory cycle. So we know normally in a 28-day cycle, you have estrogen will come for the first 14 days, and after that we get a progesterone. Because there is no anovulation, the estrogen will be there for a longer period. It may take 2 months or 3 months for the ovulation to take place. So that makes the cells more prone for that. That is what is also happening in the post menopausal. If the menopausal is going to take place at a very late age, and that is going to be important. But another very important area, which is the first childbirth. So what the Gale model says is, if the childbirth is before the age of 21, that is always a protective factor. If you are going to have the childbirth after the age of 21, that is always a risk factor. So if you see the medical student, now what I see is most of them are getting married at a very late age. So if you are potentially getting married at the age of 27 or 28 or 29, you are going to have the child only at the age of 30. 30. That is going to make you more vulnerable. So the moral of the story is the doctors should get married earlier, because that is one of the very important risk factors for you to get there. So all these risk factors are included as a Gale model. So with the Gale model, and we will be able to predict whether this lady is going to get cancer at her life or not. It's a very important landmark which we are going to have. There are different models, because one model is a Gale model. We have a class model. We have a BRCA Pro model, and we are having a Tyre-Cushing model. And this is advances which the lot of Western countries are trying to do, and they are able to predict and which patient will develop the cancer development in that. So another important point which the postgraduate and students must know is that cancer doubling time. So this is very important. Cancer doubling time is what we talk, the single cell becoming a double cells. So what is the normal time it takes for a one cell become two cell is in average, it differs from person to person, age to the chronological age. If they're less than 50%, 50 years old, and they will get in average, they will get a doubling time around 80 days. And more than 70, if they will get average is 180 days. That is what we normally say. It's a 3 to 6 months. The doubling time of the cancer cells will be 3 to 6 months. The cancer get double. So to get an 1 centimeter size solely in the breast, it has to undergo minimum 30 doubling. So 30 doubling, how much time takes? If for one doubling, you are going to have 6 months, 3 to 6 months. It average, it takes 5 years. So to understand the cancer, when you are finding out 1 centimeter mass in the breast, that means the cancer initiation has started 5 years back. It has started as in one cell, it has become a 2 cells, and 2 cells has become a 4 cells. So it starts that. And more so, what we also found out, the cancer by the 20th doubling time, that's by the 20th doubling time, you will not have the mass outside. This 20th doubling time, the cancer can start metastasis. We can spread to other cells. That is why normally the carcinoma of breast is considered as a systemic disease, not a localized disease. It's not going to spread in the locally. Before even you see the mass, before even the first symptom of the mass is seen in the breast, there will be a progression of the disease and the spread of the disease in the through the cells. So that is very important. See, doubling time you should know. So now, thanks to the AI, artificial intelligence, which has come, there is a lot of the software has come. One of the software is Esimirai. Esimirai is a one tool which can we normally do a mammogram to the mammograms of the cancer patients were fed to the AI, and their mammogram 5 years back taken were also fed. But AI was able to look at the mammogram which was taken 5 years back and say that this patient is having carcinoma. So that is a great advancements which we are taking place. Before the first cell changes which are taking place, now the mammogram which we take for a routinely diagnosed, the AI is able to take it up and it can able to tell us and whether there's a cancer is there. So the 5 years prior to the palpable mass, the now the AI. So I'm sure in the as you come predict the breast cancer, the AI is going to play a major role. The next improvement or the advancements is a molecular testing in breast cancer. So now it has become a routine that every cells, we are not going to make a diagnosis only by the histopathological or cytological. That is not the way now the cancer management is there. And always we need a molecular basis, and that is going to help us in understanding what is the gene which is mutated, and what kind of mutation is there, and what are the tumor markers which is present there. So old way, patients we take a sample, we do the pathology lab. But now the patient tissue sample or the blood sample we take, we need to send for, there is the two things we study. That is, one is called proteomics and another is a genomics. So what are the proteins which are abnormally placed there, that we are going to study by proteomics, and what are the genes which are abnormal, we are going to the genomics. So this proteomics and genomics very important, because genomics will stay at the proteomic image and microarray image we take, and there we will be able to get the molecular imaging. So once you get the molecular study, based on the molecular study, the cancer of the breast is divided into 4 or 5 categories. One is a luminal A, luminal B, normal, HER2 positive, and basal line. So what are the factors we study here? We study the ERPR, HER2, and Ki67, which is a proliferative factor. So any cells which has a ERPR positive with a HER2 positive or negative, and Ki67 is low, you have with the luminal A, that is the best possible cancer. And when there is a ERPR positive and the Ki67 is high, Ka67 always denotes that it's a proliferation of the tumor, and when the Ka67 is more, that is a bad. And the worst is a basal-like or the Claudin low, where all these things are low, negative. ER is negative, PR is negative, HER2 negative. We also call it as a triple negative. So that's a basal-like. That is a worst form of the disease, where there is the tumor markers or the tumor factors are not there. So the patient who has luminal A category, and we can predict the prognosis of the patient is much better. But on the other hand, it is a very aggressive tumor. We are going to get in a basal-like. Unfortunately, nowadays, we get more and more of a basal-like cancer that occurs in a younger age group. That is a highly proliferating one. Within a short time of span of 3 to 4 months, the disease will spread very aggressively and patient will have a very bad status. So that is another advancements with the management. Is a molecular pattern. And also, these are the different kind of tests which you do for the gene expressing. There is a immunohistochemistry. That's most of you know this, which we can do. Another important is a FISH. That is a fluorescent in situ hybridization. So all these tests, the FISH, IHC, and RT-PCR, gene microarray, and most importantly, the NGS. These are the newer advancements in testing of the molecular ways, the genetic profiling. So olden days we had only immunohistochemistry, and now FISH is a very important in the fluorescent in situ hybridization. But now certain tests which is not there in a FISH, it has to be go for the NGS. So this is important even when you are doing the HER2 receptor study. If the HER2 shows 1 is negative, 2 is mild, and 3 is, we say, is a positive. Now what we say in immunohistochemistry, you make HER2 is a 2, and all these patients should be applied to the FISH. They should go for the fluorescent in situ hybridization, and that will further say whether this is positive or negative. So these are the interchangeable tests. So you must remember at least the names of that: immunohistochemistry, fluorescent in situ hybridization, reverse RT-PCR, the reverse transcription polymerase chain reaction, gene microarray, and the NGS. And we also now have the rule in and rule out test. One of the most common tests which we do is Oncotype DX. So any woman with a carcinoma breast, they is subject to the Oncotype DX, but unfortunately it is quite expensive. It costs around 2 lakhs for the Oncotype DX examination to be done. But this Oncotype DX, which can tell us whether this patient can, your hormone therapy which you are going to give will be able to get benefited. The chemotherapy which you are going to give will be benefited. And whether this patient will, what are the possibility of this patient developing the cancer. So it is nearly 21 genes will be studied, and based on that, now most of the Western countries and in the corporate, they will subject the patient for the Oncotype DX test. So Oncotype DX test will tell us the probability of getting disease, and not only that, the predictability and how they are going to respond to the chemotherapy or the hormone therapy, and how they are going to respond to the treatment. So this is one of the very important development in the molecular biology. Molecular biology, we are going to do that, and based on this, whether this patient will get recurrence, whether this patient treatment will be good, and we are going to do that. So again, it depends upon the age group. So if the patient is having a more than 50 years patient, that is a postmenopausal woman, so the chemotherapy benefit will not be seen in a particular group of age group, particular group of people, and in particular people it will be seen. So this Oncotype DX will be able to give us the value and how we are doing. We all know ER, PR, HER2. But what is now another important tumor marker or the factor which we are studying is the androgen receptor. So estrogen receptor is there. Then what is the role of androgen receptor? Then still now we were thinking in the view, the disease is spread from the parent, that is a mother to the child, and the father has no role. But now the studies has proved that father also has a role, androgen also plays a role, and most of the luminal A cancer means ER/PR positive and HER2 negative, and the Ki67 low. So they have AR, 50 to 90% of them will have a AR positive. So now the tests are more interested. Routinely we do only ER, PR, HER2, but now we do the ER, and where the genomic signaling of the AR, interaction of the AR can be studied, and which is going to give us a more appropriate clue. There are 4 types which we do. AR, based on that, like what we said on ERPR, we have classified the molecular biology of the breast as a luminal A, luminal B, basal, and HER2 negative. Here it is there. It is a AR plus ER negative, HER2 plus, AR plus ER plus subtype. So this is a type, what is endocrine sensitive, endocrine resistant. So if he belongs to the C, there is no point in giving a hormonal therapy. And only when they are D, that we will be able to give a hormonal therapy. So next development is a ERPR, we have say earlier development. Now androgen receptor is that. This is a mechanism which I am not going into much detail. And again, what I said earlier is a HER2 receptor. The epithelial receptor factor HER2 neo2. Now another important factor is come HER3 receptor. So we now do for a few cases the HER3 receptor. It is a crucial heterodimetric partner of HER2 and epithelial growth factor family members, and overexpression of HER3 is seen in 30 to 50% of the people, and their prognosis is much better. What we are finding out. So they like HER2. There is another important is the HER3 is there. This is a HER3, and one more is a TROP2. This is not routinely done. These are all still in there, but HER3 is now, and we also know. All of you may be remembering, for a HER2 positive cancer, we do trastuzumab or Herceptin is a drug of choice. And for HER3 resolution, is a pertuzumab or the govitectin or the deruxtecan. These are the 2 drugs which has been now used extensively once you are tested positive for a HER3 receptor. So HER3 receptor study, which is a lot of papers has now come, which plays a key oncogenic role in the breast cancer, which is associated with the poor prognosis and normally resistant to our protein drugs, which were used as a targeted therapy, that is AKT or mTOR drugs. But the drug of choice for the HER3 receptor is pertuzumab, and deruxtecan drug can be given. Another important development which is now coming with the tamoxifen, which all of you know, it is a selective receptor inhibition with tamoxifen. So this is now used extensively in a prevention of the cancer. Some of the people who have hereditarily, they are prone, BRCA1 positive, BRCA2 positive, or whether their mother had a carcinoma breast. Now, there is a way that we can prevent it? Yes, now all the studies has proved, and the people who are putting a aromatase inhibitor on the tamoxifen, there is an obvious reduction in the incidence of the case. It is the tamoxifen and its metabolites helps in the blocking the estrogen receptor, which is mandatorily required for the breast cancer proliferation. So this is going to help the tamoxifen is going to help in the reduction in the cancer cases because of its virtue of reducing the cancer. There is another way of prophylactic is a mastectomy. So there is a lot of studies has proved the prophylactic mastectomy. So once you understand that you are having a BRCA1 or 2, and you understand that you are going to get the cancer, and we can have the more of a prophylactic mastectomy. All of you might be knowing Angelina Jolie, the one of the very famous person, and she had undergone bilateral prophylactic mastectomy, because she was more prone to develop a cancer, which has prevented. Now, the next advancements we see the metastatic. The carcinoma breast is always known to produce. Right from the beginning, it was thought as a systemic disease. If you have the original Hallstadian concept, where the Hallstadian concept said it is a local disease, it spreads. So that's why the Hallstadian radical mastectomy was there, where he thought removing all the chest wall and everything is going to cure the disease. But they proved that is not so, because it is right from the beginning, it is a systemic disease. So we need to find out how that is spreading. There are various ways in which the tumor spread. It goes through the blood and go to the bone. There are different areas. It can go commonly. It goes to the bone metastasis. It can go to the brain. It can go to the liver. It can go to the lung. So what is the commonest site? The lung is the common site, but the lung, which is the common site, is most often time it is not the parenchyma of the lung. The commonest site of a spread of the carcinoma breast is to the pleural. So the pleural effusion or the malignant pleural effusion is the most common cause. The second, it can go to the parenchyma, that where we can make a cannonball appearance. And the third, it can go to the, locally it can spread to the ribs and the osteolytic lesion it can produce. So the lung is the commonest site. And among that lung, the pleura is the commonest site. We always say the commonest cause of death of the carcinoma of breast is due to the malignant pleural effusion. So pleural effusion, it can go. And it can also go to the brain. Where it goes to the brain, I already said, one of the most important word which you can always remember is estrogen receptor sensitive areas. So whichever the part of the brain which are highly estrogen receptor sensitive, which is commonly we see the posterior hippocampus and cerebellum, and those are the sites where it is very commonly exposed. So it can go the hippocampus, hypothalamus, amygdala are the important estrogen highly sensitive areas. So if somebody asks you where in the brain the carcinoma of breast goes, it is going to the estrogen sensitive areas like hippocampus and hypothalamus, and amygdala is the commonest site it goes. And the bone is the common site. Usually it goes first to the Batson plexus, and through the Batson plexus, so the blood from the breast drains through the posterior intercostal veins, which has a connection to the Batson plexus via the Asaya system of veins. What is Batson plexus? This is again, most of the time when you ask this question, people don't. It is a vertebral paravertebral plexus of veins. We have a longitudinal paravertebral vein, paravertebral veins, posterior paravertebral veins. So it is a collection of the paravertebral veins which extends from the base of the skull to the sacrum. This is the one system which has no walls. So it has intercommunicated very well, and they extends from the skull to the what is the function purpose of this Asaya system and paravertebral plexus of Batson? It's all due to the natural pathway is IVC, then the blood goes to the SVC. IVC from the heart, it goes to the SVC. These two are the natural pathway. So when there is an obstruction taking place in IVC, it bypasses either through the Asayas or the basal plexus and reaches the SVC. So that is a protective mechanism by that. So from the tumor cells can go via the basal plexus to the vertebra. The commonest site is thoracic vertebra. It goes to the thoracic vertebra. Though the disease first affects the vertebra, but the osteolytic lesion takes only on the transverse, the horn or the spinous process of the bone. It is a paravertebrally, you have a spinous process of the bone. So that is a bone which commonly said. And the second commonest site is the femur. So normally we say the bone has three parts. It is have a epiphysis, metaphysis, and diaphysis. Epiphysis is always known as a growing end. It is a site where the grow, because all the nutrient vessels coming into that. So it was original, we thought that all the cancer cells will go only to the upper end. That is a growing end of the femur. So in the growing end in the femur, it is a upper end, and the lower end of the femur is a natural growing end. The one dictum we say, it is from the away from the heart and towards the away from the elbow and towards the knee joint. But in the knee, what is happening? By the age of the cancer develops only at the age of 30 to 40 or 50. By that time, the growing end will be obliterated, because after 20 years, the bone will not grow. That is, epiphysis will grow. So now the commonest site of secondaries in the femur is only upper end, though it is not the growing end, but only in the upper end of the femur, it is the epiphyseal region that you are going to get a secondary. The third type of secondary, you are going to get a Krukenberg tumor. Krukenberg tumor is always a bilateral tumor, and it is a fleshy, smooth surface tumor. It can present from the premenopausal woman. But original, again, the olden days, we say it is due to the drop metastasis, or it is transcelomic spread. But now it has been declared, it is not through the transcelomic spread, it is by the retrograde lymphatic flow. From the breast, the retrograde lymphatic flow that results in the Krukenberg tumor. Krukenberg tumor is not only confined to the breast. There are many carcinoma can produce a Krukenberg tumor. The commonest carcinoma which produces a Krukenberg tumor is CA stomach. From the CA stomach, you can get a carcinoma, Krukenberg tumor. CA breast also produces CA Krukenberg tumor. So both these tumors are due to the retrograde lymphatic spread. Now coming to the diagnosis of the cancer, what are the newer options of the diagnosis we have? we know there's one word which always we say is a triple assessment. We have a clinical examination, then you are going to have a radiological examination, then you are going to have a pathological examination with the FNAC and core needle biopsy. So in a case of radiological examination, mammography is the most important thing. What is mammography? It is a low voltage, high amperage. There's X-ray which is going to be taken for the woman in a two direction, craniocaudal and the mediolateral. So you have to compress the breast and you get a picture. That was a normal. Now we have this lot of sophistication in the mammography. The first sophistication is a digital mammography, where it is not that the compression pad will be very light and it can be taken in a digital form. So this is a digital mammography is a one advancement. And the most another important is a computer aided detection of the bed. But most importantly, now we say is a tomosynthesis. It is a 3D image in a normal digital or the normal mammography. If you are taking it is only a 2D image, but tomosynthesis is called, or the 3D mammography. It is here the patient is lying down in a table, which can be rotated, and all the 360 direction the pictures are taken. That picture will be processed by the computer, and you will be going to get. So it is a definitive diagnosis. A lot of changes are there. If you see the normal mammogram, the retroareolar area is called the blind spot, which cannot be easily detected. But digital mammography can take it out. Even the paddle size or the compression is very minimal, so it is not going to be the painful incidents for that. So the advancements in the mammography, computer-assisted mammography, digital mammography, or a 3D mammography. So if you see a 2D mammography, the picture is not clear. But when you are taking a mammography in a 3D tomosynthesis, you are very obviously see the site where the cancer is developing. So you will be able to predict that cancer very well. And now another one is a contrast enhanced spectral mammography. So like what do you know, the CT scan, when you are going to take, you give a contrast. When you are going to take an MRI, you will contrast. Now in the mammography also, we can give the intravenous iodinated contrast, and which can help us to delineate in the mass very carefully. So another advancement in the mammography is a contrast enhanced mammography. Then we have laser mammography, and we know laser is now used in many of the procedures. And here the laser, in the same way of a computer tomography uses X-ray. Here, instead of X-ray, we use the laser, and the laser will be able to give a wave. And there are ABUS is an automated ultrasound of this there. We have MRI and dynamic MRI. This is also a contrast enhanced MRI, which can help in the diagnosis of that. And the most importantly, now one of the MRI which he says, we know PET is the positron computerized chemotherapy. Computerized examination. So PET, now we have a PEM. PET is the one where we are going to do for the entire body. But the PEM is an imaging technique which is increasingly focused only on the chest instead of the imaging the whole body. So the same contrast MDG is used, but the PEM has a higher spatial resolution, and it takes less time than the PET. And now the next development is a thermography. It is not only the laser, ultrasound, contrast. It can be also as a infrared imaging. The area of the breast is imaged using infrared based on the principles that metabolic activity and the vascular circulations will be in the precancerous tissue will be more. We will be able to see the areas where that marked red on the picture, and that being said, they are suspicious area for the malignancy, so we can go for a biopsy or something. So the thermography is another important. Synthetic mammography, like a laser mammography, you can do the technetium-99 scan, can we do the technetium-99 Sestambi scan, which can be taken by the cancer cells, and using a gamma camera, we'll be able to do this. All advancement. And we also have now the advancements called the intraoperative ultrasonogram. So during the operative theater, you will be able to do. Another investigation is the highest development is the ductal lavage, and we all know the terminal ductal lobule is the fundamental unit from where the cancer develops. So we can collect materials, and cytomorphology and biomarker studies can be done by syringing through the lactiferous duct. We can do ductal biopsy. One of the most important development in the cancer investigation is liquid biopsy. We all know when we say biopsy, we know we need a tissue to be taken. And every time you need to put an injection, you need a needle or the true cut to take a tissue to do the diagnosis. But areas like carcinoma of the lung or carcinoma of the breast or the carcinoma of the internal organs, so you may not be, it is not that easy to get the tissue adequately. So now the newer technology has come. You are going to do the liquid biopsy. What is the liquid? The blood. The circulating tumor cells in the blood can be estimated. So the enrichment of the CTS by antibody-mediated targeting of the epithelial cells, and these, when you have a blood, you assess, and if the blood component has more than 5 circulating tumor cells, and then you can obviously say these people are more prone for the cancer development, or they have a poor prognosis for that. And so this is one of the investigation of choice, or the modern development which has come, is a liquid biopsy. It is going to do the greater job. Another sophisticated investigation, we have a theranostic. This is very beautiful in the sense it is not only a diagnostic, it can be also used as a therapeutic. So it is a dual role. The theranostic is diagnostic and therapeutic. That's the two words of putting together we call as a theranostic. The most of the time is that nanomedicine is used. So it is a diagnostic agent and a therapeutic agent in the nanomedicine form. It is given. So nanotherapeutic, where the integrated nanotherapeutic system can be used to simultaneously diagnose and deliver the targeted therapy. The most common nanoparticle which is used is the glycal cytosine coated gold nanoparticles. So the glycal cytosine coated gold nanoparticle, which is used for theranostic study. So you must know this word. Theranostic is both the same nanoparticle is used for the diagnosis and therapeutics. There is a lot of theranostic drugs, copper 64, somatostatin receptor, immune checkpoint receptor. In the further details, is not there. So this is one way of the interventional diagnostic, radiological diagnosis. Another diagnosis which we will commonly have a problem is a sentinel node biopsy. So we know conventionally we do a blue dye or the isosulfan blue. We inject around the tumor, peritumoral injection, and then study the tumor cells in the axilla. So that is going to give a result. But now the most important development which is coming in that is using a technetium tagged sulfur colloid, that is called CendiMag. The CendiMag, which is called a ferric oxide, we inject around the tumor cells, and that will be taken. What is an advantage? If you are doing an isosulfan blue or the dye we are injecting, it has to be done in the previous day night or on the table on that day, and you need to do the assess. So if an institution is not having the facility of the gamma camera, then it cannot be done. But here the CendiMag will be there for 1 month. So you can put that and you can send the patient out. You can take the picture and come out. You have enough time. So the CendiMag, the validity of the CendiMag injection will have the 1 month duration. So that is going to help. So this is a difference between CendiMag, gamma camera, and blue dye or indocyanine gray ICG. So where the SLN, the CendiMag has all that 3-day, 30-day injection window, is the surgeon control, avoid radiation, quantifiable sentinel node biopsy. So all this, but gamma and this, we don't have that advantage. So this is another development, is a sentinel node. And normally we have in a surgery treatment, we always talk about ablative surgeries. You know that is simple mastectomy, radical mastectomy. These are the tumors. But now we have other way of called as an ablative therapies instead of surgical therapy. These are different mode of ablations are used. But when there is a tumor is a small size, 2 centimeter, 3 centimeter, you need not go and do a incision, anesthesia, general anesthesia, and take that. Now radio frequency ablation, most of you would have known, they are radio frequency ablator. It is a heat probe, which is the temperature is raised about around 200 centigrade rise. So that can heal. You use the radio frequency ablation among the cancer cells which are less than 2 centimeter, and make the cells undergo ablation, and that will be relief of the cancer cells. This is a very important. Nowadays, a lot of centers have started doing this ablative procedure. There is a lot of different ways of ablative procedure. One of this is the radiosensitive. This radio. Another one is a cryoablation. What is the difference? Radio, there's a heat probe is used, and in cryoablation we are using a ice probe, nitrous oxide, which goes the probe is there, the nitrous oxide is passed. It will produce ice around the tumor cells. That way, necrose the tumor cells, and the tumor cells can be get ablated. So it's a lot of improvement is taken from the cryoablation, and there is a lot of immune checkpoint cryoablations are done, which not go. Another third important is a microwave ablation. It is a heat which you do. The water is heat at the frequency of the 900 to 2500 megahertz. This microwave ablation can be used for the ablation. The fourth is a laser ablation. Similarly, like use a infrared radiation, the laser. We know normally in all vascular cases there are two ways of operating: is a laser surgery or a RFA, radio frequency ablation, because both are not a competitive. We can say it's a counter supportive to each other. So laser ablation is another very important. The laser probe is passed into the tumor. The energy is activated, and thereby you will be able to get an ablative procedure. And fifth, another ablative is a HIFU. It's a high intensity focus ultrasound. So the ultrasound waves are high intensity ultrasound waves are focused on the particular tumor, and that tumor will be getting ablated. It may not be much useful in the breast because this is a little outside, obviously. But sometimes when you are going to do that pancreas, when there is internal tumors, these ablative procedures are going to be very useful. So you have a different pattern of ablative procedure, either using radio frequency ablation, cryoablation, microwave ablation, high intensity focused ultrasound ablation, laser ablation. So a lot of ablative procedures are used. Another important development in the therapy is a photodynamic therapy. See, our skin is when the photosensitizers. What do you mean by photosensitizers? Photosensitizers are light sensitive molecules which results in the cancer cell destruction followed by light irradiation. So depending upon the localization of the photosensitive, again within the cancer cell, the destruction can happen by either by the apoptosis, necrosis, or autopsy. There is a lot of materials can be used. So that helps in the accumulation in the tumor cells of the photodynamic therapy. And when you are giving this photodynamic therapy, that tumor cells can be ablated. So ablative procedures are one of the recent advancements in the management of the cancer therapy. Instead of a surgery and upfront surgery, the ablative therapy can be useful, and for different modules of ablative therapies are there, and each can in a different way. Another recent advance in the therapy is adjuvant radiation therapy, and we know the conventional radiation therapy we have to give 50 to 60 gray for 5 days in a week, and it takes 6 months to treat. And other things. Now we have a newer form of a radiation therapy, which is called accelerated partial burst radiation technique, or APBA. Here, instead of 6 weeks, the entire treatment will be over within 6 days. And you are going to give 5 to 6 days in the fraction of 30 to 35 grays, and 2 fractions per day can be given. And that is going to be that. So this is accelerated partial burst radiation. It's a newer technique where the radiation is given in a high frequency. That is all the 5 days continuously you are giving. So thereby, the total duration of the radiotherapy cure is only 5 days. Conventional radiotherapy takes 6 weeks minimum. So this is going to be a very important. There are different ways of doing that therapy. It can be brachytherapy model or intracavity balloons, which we can put in. So that is called intracavity balloon, the radiotherapy. So inside the mass itself, you put the balloon. In the balloon, you will have a brachytherapy model you have. So the another one is a non-invasive image-guided breast brachytherapy. So either you can put it inside, or using the NIBB model, you can give a therapy. So the 3-dimensional radiotherapy. These are different radiotherapy model. IORT is another important there. It is an intraoperative radiation. When you are going to do the surgery itself, and if you see there is you are not very sure that you are get a tumor cells clearance you are taken, and that times you can do intraoperatively also you can do. What are the common drugs which are used in the brachytherapy? Iridium-192. So that iridium-192 needles can be flexed into the mass, and that can do that. The most important development which is taking place is the vaccination. So can we prevent the development of the cancer? There's a lot of studies that being done. We are on the verge of releasing the vaccine, because almost the type 3 trial has been over. Now, very shortly, you will be giving a vaccine. So there are different kinds of vaccine. One vaccine is based on the alpha-lactalbumin, which is called as A-lactalbumin. So this vaccine is one of the very important work which is happening. Another important is happening in Western countries is kind of vaccines. Mammoglobin A is another vaccine which has been tested and finding out in a very positive way is a mammalian DNA vaccine. It is helpful in preventing the cancer. This also, now this is a good news which has come very late. The Times of India has reported for a triple negative breast cancer. That is a basal like type where there is a hope is less, because that is going to be a very aggressive tumor. For that also, now we are developing a therapy. The another important therapy is a targeted therapy. So there are so much of drugs we have. So these three words, gene therapy and immunotherapy and targeted therapy, you should know the difference for that. So in the fundamentally, the cancer is a mutation taking place in a particular gene. Any gene which undergo any problem, there you are going to get a problem. So now we know who is a culprit. Here the culprit is a gene. The particular gene which is mutated is a culprit. How you are going to tackle that is going to be said as a three different ways. So one way of tackling that, there is somebody who is a culprit, surrounding him with a police, surrounding it with your army, and making that is not able to perform, that not able to act. If you are able to stimulate the immune system around the body, significantly they can potentially make the cancer cells to not to replicate, not to act. Is the ways there are so many drugs comes on to work on a immunotherapy. So what is last one, targeted therapy? We know very recently, we know the Sindhu, the Pakistan army was targeted and the attack was done on them, they destroyed. So similarly, targeted therapy, when we know there is a culprit who is there, BRCA1, so you find out a vaccine, HER2 receptor is there, you find out a drug which go and act on that particular mutation and kill that, destroy it. So if you are able to have doing that, that is called targeted therapy. There's a third variety, is a gene therapy. The same gene is mutated. Now we have now a lot of gene-based tomatoes, gene-based vegetables are coming in. What is that? They send a gene which will just reach that particular mutated gene and alter its structure, so that the functions of the cells will be not able to do the proper. See, we know the tomato, which is the size is slow and it is easily perishable. Now we are making a vector gene is put into the tomato, which makes it larger and non-perishable one. So similarly, the gene therapy is one which is going to reach the mutation gene and which is going to alter that. So these three words, because it is repeatedly, it will be asked in your exam, what is immunotherapy, what is a gene therapy, what is a targeted therapy. Targeted therapy, you are going to using some object to target that gene and destroy it. Immunotherapy, you are going to build the army around the particular mutated gene and you are going to make the life easier. And the gene therapy, you are going to alter that. There are a lot of drugs. We have ER receptor, we have tamoxifen, aromatase inhibitors. We have trastuzumab for the inhibitor, and this is a huge number. I'm not going to confuse you with that. Gene therapy, there are a lot of genes are being now approached. There is one important gene therapy called suicidal gene therapy, which go into that and make the cells to commit that, get the particular gene to commit the suicide. So that level, now the therapy is being increased. So this already I have talked, and finally, I think another 5 minutes I will be able to close for the recent advances in the surgery. What we initially, if you see in the 20th century, the surgery was a radical mastectomy. They take the pectoralis major and extensive surgery. But now in the 21st century, it is a breast conservative surgery. So even the simple mastectomy is now changed to the breast conservative surgery. And most of the patients will be do the breast conservative surgery. This is a different time zone in which it is developed, which we do not know. So BCT, is there is any contraindication? Yes, absolute contraindication when there is a diffuse macro calcification on a mammography, and if there is a persistent positive margins after reasonable surgical attempts. But there is all others are relative. The size of the tumor, the pregnancy, and large size, all that is that. So we are not going to do that. Breast conservative, what are the breast conservative surgery? Quadrantectomy, lumpectomy, partial mastectomy, or wide excision. All these are called partial. That there is another term called skin pairing mastectomy, where there is a nipple and areola will be preserved when we are going to do the mastectomy. So this breast conservative surgery is a recent advance and very good. Uh, what are the few contraindication? Pregnancy is relatively contraindicated because always the BCS is followed by radiotherapy. So if the patient has undergone a BCS, breast conservative surgery, that should be given, that area should be given radiotherapy. In pregnancy, it is contraindicated because in a pregnancy, you will not be able to give a radiotherapy. So if it is a pregnancy, so the third stage and third trimester, you can still do the BCS, and radiotherapy can be given after the delivery. Tumor size is not a problem. Anyway, a larger tumor, you can give up the chemotherapy drugs, the size can be reduced. Multicentricity, yes, it is relatively contraindicated for that. Tumor grade, tumor class, I'm not going to the much details of that. Now, finally, I'll talk few words on the oncoplastic surgery. Now, this is a very important thing which is coming. It is when there is a tissue loss, when you do a quadrantectomy or when you are lumpectomy, a large portion of the breast tissue is lost, you can do the extensive replacement. There is two things we have. One is a volume displacement and volume replacement. When the size of the tumor mass which are removed is less than 20%, you can do the volume displacement. When there is a more than 50%, we have to do the volume replacement. There are different kinds of surgeries. I'm not going to the details. So, but always this is going to help us in the development. So we have covered the few newer the concept which you know. Breast carcinoma is a metabolically active disease. So metabolic features like sedentary lifestyle, loss of sleep, alcohol, smoking, not breastfeeding, all those can predispose development. Age of the marriage, age of the first childbirth, all that is going to develop. So we need to adjust our life. In the diagnostic model, so much of mammography was there, was one model. Now digital mammography, laser mammography, infrared mammography, so many things has come. And the third, ablative procedures are coming into play than the surgical procedures, and the different kinds of ablative procedures are there. Radiotherapy, so much of advancements are taking place in the radiotherapy. Surgery, from the big surgeon making big incision concept is changed. We are always talking the minimally invasive surgery, and breast conservative surgery is going to be the major development which is going to do that. But whatever said and done, the breast cancer, its development is very high. Number of cases are so high. We need to be more vigilant and more active to early diagnose it and treat it appropriately, so that we will be able to give at least 60 to 90% cure in a stage 1, stage 2, and even stage 3 cancer for the carcinoma of the breast. So thank you very much for listening to the lecture. I'm not going to the further. With this, I'm closing the session.
Participants, whoever has any doubts, please drop them in chat box.
The last two lines can be read. The
So
last
we have
two lines.
okay. So we have a question, sir. What concrete strategies are implemented to strengthen screening programs and cancer registries globally?
Very important question, because as we always say, the early diagnosis, one of the most important early diagnosis is by the self-breast examination. Now, it is a passion for all of us doctors to teach, including the medical students and the college students, right from the age of 20, they dare to do the self-breast examination. And if there is any small change in the breast, and they have to report. That it is very easy. The models are very easy. You need to stand in front of a mirror on a particular day. Probably it is your menstrual day after the 7th day of the menstruation, or even your birthday date, if you can remember. Every 14th, maybe your birthday. So every 14th, you are going to do the breast examination, standing in front of the mirror while taking bath, or just slowly moving around the breast in a circle and feeling every part, inspection and the palpation, the self you have to do. And if there is any change, you have to bring to the notice of the hospital. So this is a one awareness we are going to build. Second is, at the age of 40, it is a mammography is one of the most important predictive factors which you can do. And otherwise now, we don't say it is only the underprivileged people. I have seen a doctor, a lady doctor, coming to me with the stage 4 fungating ulcer in the carcinoma breast. So we cannot say it is the population is low. Poor people are only not underreporting. Even our educated people are now underreporting for that. But if we can reach the medical associations, we are trying to reach, teaching them self-examination, and providing the opportunity for the medical exams at the earlier part by mammography screening. And all the institution, we have requested the government of India to notify that when they are submitting for the annual health verification reports, mammography is a mandatory part when you are more than 40 years of age, and at least once in 2 years or once in 5 years they should do a mammography examination. That's the only way we can do. So here only the knowledge and awareness is the solution which we can think of, equitable the identifying the cases. But on the contrary, what we are getting is that the incidence of carcinoma breast is low in poor people who are working in the field, who are very active, who are not taking the high-fi food diet. The incidence is low. The incidence is high in the metropolitan cities, where the woman taking alcohol, woman taking burger and pizza very commonly, and who are taking the hormone replacement therapy to sustain their feminine good, who are not breastfeeding. It is common. So there is a positive variation in the rural urban incidence of the breast cancer is also there.
Sir, what are all factors influencing tumor doubling?
Tumor doubling time depends upon your age. So the lesser the age your cancer comes, it is a more aggressive. And if the cancer is a triple negative cancer, that is you are going to have a ERPR negative cancer, it's a fastly growing. That is going to make it go ahead. So that is what one of the factor is called as a Ka67. That is going to tell us this is going to be a progressive tumor or less progressive tumor. When your Ka67 value is high, you can predict the doubling time is going to be very high. So it is definitely the two important factors is your molecular biology and the your age. Age is in a 70-year individual. If the cancer is coming, it takes 6 months to double. But if it's a cancer is coming as a 30-year individual, it takes hardly 1 month or 2 months to double that.
Thank you, sir. Okay, one more doubt is there. Are the advanced therapies accessible to low-income patients?
Absolutely, because most of the medical colleges in India, especially in Tamil Nadu, have all these facilities. Now, breast screening and viability screening is being done in all the medical colleges. Mammography is done in all the medical colleges. And once the mammography positive, doing a biopsy is also being done there. So most of the institution has now radiotherapy, chemotherapy, surgical facilities all there. Probably we cannot say about the ablative procedures that is not available in our medical colleges as such, but the treatment facilities are available, which is been good effective treatments are available in the medical colleges.
Thank you, sir. Thank you for the master class in the modern oncology landscape. Your insights into how innovation is moving toward personalized, precision-based therapies have given us a profound sense of hope, the very theme of this session. Understanding the shift from one-size-fits-all treatment to targeted care is vital for every aspiring and practicing physician here today. On behalf of Medicine, I would like to extend our deepest gratitude to you, sir, for taking time out of your demanding schedule to mentor the next generation of doctors. Your leadership continues to be an inspiration to all of us. I also want to thank our participants for their active engagement. We hope this session has added a new dimension to your clinical perspective. With this, we conclude today's academic address. Thank you all. Thank you very much, sir. Thank you.
Thank you. Thank you. Thank you all, sir. Before we conclude, I have to share a small behind the scene moment with our audience. Earlier today, when I spoke to sir, he mentioned that he had tied up with a tight schedule and asked if we could keep the session brief. But as you all witnessed, once sir started teaching, his passion for subject and his commitment to students took over completely. So he didn't even touch the subject. He actually covered every nook and corner with incredible depth. That is what I believe the mark of true teacher. A true educator cannot limit his time or knowledge when they see students eager to learn. So thank you so much, sir, for showing up today within your tight schedule and a teacher's dedication, which is shown today. And medicine is honored to have you here today, sir.
In fact, in between when I am lecturing, I am signing a lot of papers. People are coming in and signing. There's a lot of issues there. So it is fine. It's always I love teaching, but thank you very much for the opportunity to be with you.
Thank you. Thank you so much, sir. Thank you, sir.